Hello, and thank you for viewing our webinar sponsored by Simon's VIP Connect titled Psychotropic Medication Use in Children with 16p11.2 Deletion and Duplication. My name is Stephen Martin, one of the study coordinators for Simon's VIP Connect, and I'm joined by Dr. Neel Soares, Developmental Behavioral Pediatrician at Geisinger's Autism and Developmental Medicine Institute. During this presentation, Dr. Soares will discuss medications used for behavioral difficulties in children with 16p11.2 deletions and duplications, as well as the roles of caregivers, parents, educators, and medical professionals in the management of those medications. Following the presentation, we invite you to submit any questions you have for Dr. Soares by emailing the Simon's VIP Connect coordinator at coordinator@simonsvipconnect.org. Now it is my pleasure to introduce Dr. Neel Soares. Dr. Soares received his medical school training from University of Mumbai, India, and pediatric residency at University of Illinois at Chicago. Having completed his fellowship at University of Maryland, Baltimore, he is a board-certified developmental behavioral pediatrician. He came to Geisinger from University of California, Los Angeles, where he was director of the Developmental Behavioral Pediatrician Fellowship Program at the David Geffen School of Medicine at UCLA. He has held leadership positions in the American Academy of Pediatrics and the Society for Developmental and Behavioral Pediatrics. His areas of interest are technology applications in children with autism spectrum disorder and telehealth to reach patients in all areas. Thank you for joining me, Dr. Soares. I'll let you go ahead and get started.
Thank you so much for that introduction, Steve. It is my pleasure to present the topic, psychotropic medication use in children with 16p11.2 deletion and duplication. I wanted to right off the bat state I have no financial conflicts of interest with the content presented herein, and this webinar is for informational purposes only and does not constitute direct medical advice. If you do have questions about a child-specific medication or condition, I strongly recommend discussing that with the child's treating physician or specialist. The outline for today's webinar is basically to understand what behavior difficulties occur in the 16p11.2 deletion and duplication population, what is the difference between behaviors and disorders, behavioral disorders, what role does medication play in managing problem behaviors, and what roles do caregivers and parents have in medication management, and how they can partner effectively with educators and medical professionals in that medication management. So let me first talk about a not uncommon scenario. You have a young boy who has 16p11.2 deletion, and he also has developmental delay in several areas, and he has been attending school. He's been followed for his health care by his pediatrician, and he has been receiving services in the school under an individualized education program, or IEP, and some people are familiar with that term, and has continued to struggle though with his academics. And in the last few months, his fourth grade teacher was repeatedly mentioning to his parents that he has become very forgetful in class. He needs reminders to complete his work. He gets out of his seat and wanders around, and this is somewhat disruptive to the class. And so his mother takes him then to the pediatrician, who thinks that he might have attention deficit hyperactivity disorder, or ADHD. And the pediatrician suggests that maybe a specialist needs to look at that to make a formal diagnosis and prescribe medication. So a common question asked is this behavior consistent with the 16p11.2 deletion or duplication group? And really, there is not enough information out there in the research literature to say that there is one consistent behavior pattern, or what we call a classic behavioral phenotype. There are variable accounts of problem behaviors, as was reported in the unique group, and some studies have said there's more ADHD and some says not in children with 16p11.2 deletion and duplication. So my honest feeling is this is not a classic behavior for a particular chromosomal disorder. In fact, it should be considered as similar to other types of behavioral disorders, just so happens to occur in this population. And before we move on, I wanted to sort of sort out what a behavior is and when can it be called a disorder. So for that type of definition, we look to what's called the Diagnostic and Statistical Manual of Mental Disorders, the DSM, so to speak. And it is currently, since 2013, in its 5th edition. And this book, this volume, outlines the various mental health disorders, and it's based on these criteria outlined in this book that diagnoses are made by various clinicians. Now, what a disorder is, it's a collection of symptoms or behaviors. But the key is that you don't just have the behavior, the behaviors actually interfere with the way you go about your life, daily living skills, your educational life, your social life, your job-related work. And so while disorders consist of a group of behaviors, not all behaviors really qualify for a disorder. It really depends on how severe the behavior is, how frequently it occurs, and how it impacts. So an example could be that very child could be getting out of seat and moving around the room. But if they finish their work on time without reminders and they're not bothering anybody and the teacher's okay with it, then I would hesitate to consider that a disorder. It certainly is a behavior, but it may not be adequate to be called a disorder. And in general, you can't treat a name or a condition or disorder, but you can treat or try to treat some of the symptoms that occur within it. So as an example, I thank Dr. Hansen and Dr. Bernier for their slide from the family conference that they recently presented for the Simon's VIP group. And here we see on this slide the 16p11.2 deletion group. And as you can see, there's no only one column there. It's not just one or two. They spread across. Children with 16p11.2 deletion can have autism spectrum disorder, which is the ASD, can have language disorders, can have motor coordination disorders, can have ADHD, intellectual disability, the whole gamut of things. And this is also true when we look at the duplication group. There's no single bar which is unique, and therefore it comes back to the fact that a variety of different behavioral and mental health disorders can occur in these populations. So as such, we need to look at what the behaviors are and how to address them. In particular, the autism spectrum disorder and intellectual disability are important because individuals who have these conditions are at a higher risk for having certain behavioral disorders. The 16p11.2 deletion duplication group account for 1 to 2% of all ASD cases out there, so it is not an insignificant contributor to the population of individuals with autism. Intellectual disability, which used to be called pejoratively mental retardation in the past, actually is a definition that involves impairment of your general mental abilities, and that interferes with the way you think, socialize, and conduct yourself in life. And usually this is a developmental disorder that is lifelong and starts early in life. So as I said, individuals with these groups of disorders have a higher risk of having mental health or psychiatric disorders. Now that we've understood the difference between behavior and disorder, we need to understand the behaviors themselves. Why does a child do what they do? And I often say that it's more important for somebody to tell me why someone does what they do rather than what they do. And this comes down to what is called a functional assessment of behaviors, or the famous ABCs. Antecedent is what happened just before the behavior occurred. So for example, somebody's screaming. I'm interested to know what happened in the couple of minutes before they started screaming. So I'm then looking at the antecedent. The B, or the behavior, is actually what's occurring. Somebody is hyperactive, somebody's throwing a tantrum, somebody's getting very panicky. That is the behavior. And the consequence is what happened after an individual performed that behavior. So did somebody react to them? Did they get punished? Did they get to leave the room? Did they calm down? So that's what the C is. So the ABCs help one understand behaviors and therefore can help one drive what strategies need to be put into place. The strategies could either change the antecedents or change the consequences. And by changing the A and the C, you can impact the B. So an example is if the child in the vignette is not paying attention in class. I'm asking the question is, could the child be bored? So is the antecedent, the work is too hard or too easy? The child could be deliberately avoiding work, either because it is too hard or too easy, or because they have something better on their mind, or is the child not feeling well? So medical antecedents are really important. Somebody who has a toothache, somebody who has a headache can have inattentive behaviors. And so psychotropic medications wouldn't work to change these type of situations. This is where behavior strategies come into place. So you might argue then why do we need to consider medication at all? If you can tell what's causing a behavior and how one reacts to it, and you can attempt to fix that, what is the purpose of using meds? Well, the purpose is that all behaviors originate in the brain, and the brain has a vast number of different places that chemicals, brain chemicals, also called neurotransmitters, act at different points in time, all the time, in different ways. And if there's an imbalance in this, either too little or too much, either temporarily or permanently, then you can have behavior conditions appear. And medications actually work to circulate to the brain and actually change some of these chemical levels, and thus then influence the behavior. So for example, ADHD medications will affect neurotransmitters or chemicals called dopamine or norepinephrine, whereas antidepressants, anti-anxiety medications affect a chemical called serotonin. However, it should be remembered that medications don't actually teach a child not to do a certain behavior and have a more appropriate one. It just alters the chemicals. The behavior strategies help then mold certain appropriate behaviors. So medications always go hand in glove with behavior strategies, never by themselves. What is the rule for medications in behavior management? So always consider medications if the behavior poses a significant risk of physical harm, either to oneself or others. So severe aggression towards people, hitting them, causing injury, or injury to oneself is one of those criteria. Another is if a behavior interferes with learning. So in the child in the vignette, if his grades are plummeting and if he's unable to listen to the teacher instruction, then it is interfering with learning and with skill acquisition. What if it causes significant stress to other people? And I use the word significant here. It can't be just an annoyance to a parent or a teacher. It has to be something that causes stress enough that it impacts or it impairs the way the adult can function or interact with the child. And then when behavior strategies alone do not help. So these are some of the reasons why I would consider medication either early in the process or by itself initially. So once it's been determined that possibly a child needs medication, referral to a specialist is placed. Now there are many primary care providers, pediatricians, family practitioners, nurse practitioners, who are quite comfortable doing what I will outline in the next couple of slides. But in general, specialists who are tasked with this process would be developmental behavioral pediatricians like myself, child neurologists, or child and adolescent psychiatrists for the children population. And of course, given that these are lifelong disorders, they're concomitant counterparts in the adult medical world. However, which one a child goes to depends on what is available in the area, what the primary care provider knows, is aware of, and trusts in terms of specialists. And sometimes it's also dictated by insurance, depending who is within the network for that child's insurance coverage. Now, each one of these different specialists adhere to their own professional guidelines, and sometimes, interestingly, these guidelines do not always overlap. So there may be differences in how the diagnosis is made or how medication management is conducted. So what should a family expect at a visit to the specialist? So often, almost all specialists will try to get to the bottom of what's going on. They'll ask for history, either collected from past records, electronic health records, the primary care doctor, but they want to know what the medical issues are. They want to know what the behaviors are and try to figure out that antecedent of what's driving these behaviors. They want to know if the child's been developing appropriately, if there have been delays or deficits in skills, because this could contribute to the behavior problem. And family history is important to see if there's a family history of psychiatric conditions, but also to identify psychosocial stresses and situations that could be making the behavior worse. So again, coming to the antecedents. An examination of the child will really include not just the physical exam that people are used to in a doctor's visit, but also observations of the child's behavior either in the room or in the waiting room or interacting with siblings or other children. A review of records is very critical because the child's behavior in the doctor's office may not be the same as how the child behaves in the school and home. So getting records from the teachers, from therapists working with the child are important. Often a physician will provide forms or what are called checklists to family members and to give it to the school to try and get some sort of a calculation or an understanding of these behaviors, how severe they are, how often they occur. And sometimes there will be direct testing done on the child. For example, some psychologists working with psychiatrists might conduct IQ testing or some additional behavioral observations in the office to get a sense of the child's behaviors and abilities. So once it's been determined possibly that medication needs to be used, the question is what types of meds? There's a universe of psychotropic medications out there, and one has to be judicious in the use of them. So which behaviors need to be addressed? You have medications for things like hyperactivity, impulsivity, and inattention. You have medications for anxiety, including obsessive-compulsive symptoms. You have medications for aggression and injury to oneself. You have medications for tics and repetitive or stereotypic in the autism spectrum disorder population. This is sometimes referred to as self-stimulatory or STIM behaviors. You have mood volatility, very labile mood, somebody who swings from being happy to angry to sad, back to happy in a short period of time. And then you have depressive features. So each one of these different groups of symptoms have medications which can target them. It's important to understand what's the difference between an approved medication and an off-label medication. So the Food and Drug Administration approves medication in the United States, and off-label just means this medication, when it was approved by the FDA, was not approved for this purpose per se. It doesn't mean that it cannot be used, and in fact, in many of these psychotropic meds in children, these meds have been used off-label, because physicians use their discretion as allowed by their medical license. And there hasn't been a lot of research in children alone. Much of it has been done in adults, and then we use the results in children. So there are fewer drugs which were specifically tested in children that can be considered approved in that population. It's important to note that there are some psychotropic medications which have what is called warning labels, or the most serious one is called the black box warning. And families can see this on the side of the box when they pick up the prescriptions. And it just means that there are some serious side effects that need to be watched for. Some examples are antidepressant, anti-anxiety medications actually can increase the risk of suicidality in children, adolescents, and young adults with depression. And some of the ADHD medications called stimulants can increase the risk of abuse of the medication, becoming dependent on it depending how they're taking it, and in some cases some cardiac side effects if these medications are abused. So a good question that gets asked is, so should I be careful in a child with 16p11.2, either deletion or duplication, whether certain medications are to be used more or less? And there's really no evidence that certain medications are needed only in this population or need to be avoided in this population. One thing to note, though, is that in some children, there may be difference in their brain pathways and the neurochemicals, the brain chemicals. And so the medicine that is used for a specific purpose might actually show an opposite effect. So for example, if somebody has 16p11.2 deletion and autism spectrum disorder, and they happen to have attention span problems, and we choose to use a stimulant medication, it might actually make them more hyper or more inattentive. It's just because even though the med does its job in attacking the right chemicals, maybe the balance of chemicals in this child is different, and so they react differently than what was expected. And it's sometimes really hard to determine what the effects of medications are. For example, in depression and anxiety, you require the person to tell you how they're feeling, and you want to see if they're feeling more upbeat, less depressed, or less anxious. And children who have language difficulties might have a hard time expressing this, so it will fall upon the teachers and the parents and caregivers to interpret the behavior they're seeing, because the child may not be able to voice how they're feeling. We are not going to discuss every single medication. It's beyond the scope of this webinar. But what I can do is point you to some helpful resources, and we'll go through this again at the end of the webinar, that exist to get a lot of information for parents and caregivers and teachers about psychotropic medications. Two very valuable resources are the American Academy of Child and Adolescent Psychiatry, and their website is out there, and the National Institutes for Mental Health, and their website is on there too. There's also a good book by Mina Dalkin talking about helping parents, youth, and teachers understand medications for behavioral and emotional problems. And this is widely available both in bookstores as well as on online booksellers. So here's a not exhaustive table of medications that I used across the board in children with behavioral disorders, not necessarily only for 16p11.2. And they're grouped into classes for ease of understanding. Some of these have generic names, and I have attempted to use generic when available, and some of them are only brand as far as currently. The stimulant group and the non-stimulant group, the first two groups, are traditionally used in attention deficit hyperactivity disorder, ADHD. And you have a variety of different medications. I tend to prefer long-acting medications because in most children who are at least school age, they're at school for half the day and at home. These medications usually last throughout most of the day, not all of them. And so it reduces the need to then have more than one dose. In the shorter acting varieties, which last for shorter periods of time, you might need to give more doses in the day. So for convenience and because it lasts through the day, I tend to use the long-acting stimulants. I will also use non-stimulants because there are some children who don't react very well to stimulants. Either it does not work as well or has a lot of side effects. This group is relatively newer for ADHD as compared to the stimulant group, but they're still effective and they have their own side effects. Sometimes more than one of these medicines will be used, so a stimulant may be combined with a non-stimulant. For example, the stimulant can be used in the morning and the non-stimulant at night to help with sleep, or late in the afternoon to help with some moodiness that can be there when the stimulant wears off. Again, it's beyond the scope of this webinar to describe every side effect for every group in here, so I would defer that for now. The selective serotonin reuptake inhibitors, also popularly known as SSRIs, are used both for anxiety and depression, and people find that interesting, is that how can depression and anxiety, which look very different, have the exact same medicine? It's because, interestingly, they share the same neurochemical, which is serotonin in many cases, and these medications affect the levels of serotonin. And these are the generic forms that are listed out there. They've been around for some time. Some are newer than others. And usually these are pretty long-lasting, get dosed only once a day, some in the morning, some in the evening. Rarely they may be more than once a day dosing. It's generally not recommended. Again, more than one of these classes can be combined. You can have somebody on a stimulant as well as an SSRI if they have got more than one condition, and we'll talk about that in a second. The tricyclic antidepressants are also antidepressants, just like the SSRIs, but they have fallen out of favor just a little bit over the years. They've been older than the SSRIs, but they have had more side effects, especially related to the heart and just in terms of general feeling. And so the ones that are used now are generally used for other things, like if you've got bedwetting, then people will try imipramine, and some of them are also used for migraines. The atypical antipsychotic group has been growing rapidly. These are the ones which mainly affect psychosis and schizophrenia, but they've also been approved in bipolar and mood instability, and a couple of them have been approved in autism spectrum disorder, irritability, and aggression. These tend to have a lot more side effects than the previous groups mentioned. They also tend to be the ones which you need to check blood on quite regularly to make sure that the cholesterol and blood sugar, and in the adolescents, prolactin hormonal levels are stable, because they could interfere with that. They tend to be used more frequently in younger kids with aggression, though I really disagree with that, because again, without understanding the behaviors, going to medication just purely for aggression is a little challenging. The mood stabilizers have been traditionally used in individuals with seizure disorders, so they're also called anti-epileptics, but people found over time that they're very helpful in controlling mood volatility, and so they have been used for people with bipolar and other mood disorders. They also need blood checked, some of them, to make sure the levels are okay and they're not causing side effects. Those were the older ones which needed the blood checked, and the newer ones tend not to over time. Some of the golden rules of medication use, and some of these statements have been adopted from Carol Schall's work from 2002. Start low and go slow, and that's a really important mantra. Don't start a child on a medication at the highest dose or near the highest dose, even if it's pretty severe behavior, because different children respond differently to medication. So starting at the lowest possible dose, even if it's found not to be super effective, at least allows you to move it upward and get the parent and the family involved in the process. It will take input from everyone, the family, educator, therapist, so there's shared decision making, and it's really preferable to just use one medication for the symptoms. So if somebody has hyperactivity, I don't like at the same time using both a stimulant and a non-stimulant. It's very important for the prescribing physician to share information about effects and side effects and tell the family how they can monitor this at home. Regular follow-up is important. It really depends on the clinician, how often they want to see this child back and what they need to do when they follow them up. And I usually recommend changing a medication only if it is ineffective, it's not doing its job, or the side effects are unacceptable. And unacceptable is really important, because every medication has side effects. You don't want to stop something for a side effect that was temporary or can be worked through by other means. An important piece of this is what is considered complementary and alternative medication, or CAM. And these are your herbal and natural and other products, but they're actually more than that. They're actually a group of diverse medical and healthcare systems, practices, and products that are not considered conventional medicine, allopathic medicine as practiced in the United States. Families often will choose these because they're concerned about the safety and side effects of the prescribed medications that I've mentioned in a couple of slides earlier. And they also perceive them as natural and therefore more tolerant of them. However, it's important to know that the research has not provided adequate information on whether they're safe and effective. In fact, there are some CAM which are used that are generally considered unsafe. Things like putting a child in a hyperbaric oxygen chamber, using chelating agents which had been used in the past by some practitioners of CAM for individuals with autism. And so it's important to be aware of what these are, how they can interact, and that really involves a discussion with the child's treating clinician provider. Research has shown us that very few families share information, but it's important to have an open dialogue to monitor the side effects and make sure there are no interactions. Families rightly have been concerned about sharing this information because they're afraid that physicians might just dismiss their use of CAM or be unwilling to be a partner with the family in discussing CAM, but we do know that open dialogue does promote better collaborative care. An important thing, of course, in medication is pill swallowing. Not all children are very adept at swallowing pills. It can be problematic for some who have difficulties with swallowing and oral motor. Some of them are very sensitive to touch and taste, and they really don't like, some of them, the appearance of pills. And so even though there are liquids and chewable and skin patches out there, pill swallowing actually makes it limited what you can use. So, for example, the non-stimulant medication. The non-stimulant medication, one of them comes as a patch, but the rest of them are pills which really can't be chewed or crushed. Some of them might, but again, that sometimes defeats the purpose of the longer-acting formulations. Some children just were never asked to swallow pills, have never been expected, and they don't know how to do it. So there's a wonderful website out there that is run by the Long Island Jewish North Shore Healthcare System called pillswallowing.com, and it has various tricks and techniques and videos to guide people, both families as well as professionals working with children, to help them become more effective pill swallowers. So the important questions that families need to ask their doctor or their prescribing clinician is, why is this medication needed for my child? Which type of medicine are you going to consider, and how long will it take for me to see the effects? What type of side effects should I expect? What should I do if I see these side effects? Very often parents will panic, and if we think through it, there are ways to handle even side effects which seem pretty scary. How will we know when it's time to increase the dose? Sometimes people do it too soon, too late. When's the right time to revisit? So, for example, a stimulant medication can pretty much within the week tell you whether it's working or not at that dose. But antidepressants usually can take up to a month to 2 months to really show effect. So it's important to know how long to wait before you start changing dosing or even changing the meds. And it's important to know when is the right time to change the meds. When have we tried our best in figuring out whether this is the right medication and it's not working and to switch to something else, either a different medicine from the same group or maybe even change a group. It's important to families to know what they should do when their child is on medication. And I always say, don't try to treat two things at the same time. Prioritize the behavior problem. So if somebody has anxiety features and ADHD features, pick the one that you feel is the most impacting. Get that relatively under control before jumping on something else. It's also important for them to notify their doctor either through phone calls or through visits or other electronic messaging about the effects and side effects, so the doctor then knows how to make the next decision. Always inform about herbal over-the-counter CAM medication, because you want to be sure it's not interacting with anything. For example, the antidepressant prescribed medication could interact with St. John's wort that people often will use as an herbal remedy for depression. It's also important to inform the clinician about new stressors, changes in life situations, so they understand what some of the possible antecedents for these behaviors are. And families and therapists and educators can educate themselves about medication, both by getting information from the doctor's office, but also looking at some of the reputable websites, which I outlined before and will show you again. And just like they have an action plan for natural disasters and the schools run fire drills, it's important for families to have a medication list and an action plan, just in case their go-to doctor is not available or they have to deal with somebody in the emergency room or a new healthcare provider. They can bring them up to speed with what's going on with their child's medication. How do therapists and teachers and paraprofessionals play into this? Well, they're really, really important, because they can see the child in the schools, daycares, and other natural settings where the clinician cannot reach. Sometimes the child shows different behaviors in the doctor's office than in school or at home. And their input is very important in tracking of the behaviors so that it can be decided what to do with medication. So either through their notes or communication logs, report cards, progress notes, or some checklists, we can get information. But I really find it important to keep, at least initially, the school teacher and the therapist blinded to the med trial. And what that means is they should not know when the parent is giving the medication, and you want to see if they can tell if there's a difference in the child's behavior in school or on the playground or what have you. Communication between all entities, the family, the school, and the healthcare providers, becomes really, really important. And unfortunately, because of various laws out there, there is a limited amount of communication. And This is well-meaning so that there's no abuse of the privacy rights of individuals. So for example, in the school system, they have the Family Educational Rights Privacy Act of FERPA. And in the healthcare system, we have the Health Insurance Portability and Accountability Act, popularly known as HIPAA. And this limits communication. So families and caregivers and parents can facilitate this by signing releases of information, and this allows the school and the physician to communicate. Alternately, they could actually shuttle documents back and forth, bring report cards, bring checklists, and families can collect their own data and they can present this. They can see how the child's doing on play dates in their home environment. But again, if the family is giving the child a medication, you'd like to have at least one person not know the medications in to give a true unbiased opinion. This is easier said than done, I recognize. Some of the resources I alluded to where you can get a lot more information about medications, details about them. There are family handouts and other reports from the American Academy of Child and Adolescent Psychiatry, the National Institutes for Mental Health, and for the complementary and alternative, you have the National Center for Complementary and Alternative Medication, or NCCAM. There's a good book out there by Henry Paul about When Kids Needs Meds for parents about psychiatric medication as well. And there are others. The list can be exhaustive, but these would be a good place to start. The most important resource, though, is the child's primary care provider. They know the child better than anyone other than the family. They are aware of resources of specialists in the area, so child adolescent psychiatrists and developmental behavioral pediatricians are valuable resources for families. There are parent support groups. For example, there's one for ADHD families called CHAD, another one, Anxiety and Depression Association of America, ADAA, and the Autism Society of America. So all of these could be places, forums, discussion points for families to discuss their concerns and questions about medications with other individuals. In summary, I'd like to state that some children, not all, with 16p11.2 deletion and duplications may be placed on medications to help manage problem behaviors. The treatment with medication is a family decision. I never like telling a family they need to have a child on medication. It's their decision. And the use of prescription medication is not necessarily right for every child with a behavior disorder. Some of them might do better with behavioral strategies. There is no medication that treats the core genetic etiology of the 16p11.2, either deletion or duplication, so it's mostly for the problem behaviors that exist. It's very important to keep the communication lines open between the physicians, the educators, and the family, and this will help in improved medication attempts and monitoring. It's always important for families and educators to educate themselves about medications from reputable sources, because there's a lot of myth and hype out there, and so they've got to drill down to what's the information and how does it apply to my child. I want to thank you for your attention to this, and I will turn it back over to Steve about what is the way to send additional questions to us so we can address this. Again, I'd like to reiterate that this does not constitute specific medical advice to your child, and so if you have questions specifically about your child's medication, I recommend that you contact their prescribing provider, but I'd be happy to address questions about medications for behaviors in general. Steve?
Thank you so much, Dr. Soares. And thanks to everyone for viewing our webinar. Please remember to submit any questions for our presenter to coordinator@simonsvipconnect.org. And please check back soon for future webinars as well as our archive of current webinars. Thank you again.